Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
Hello, good morning, doctor.
Good morning. Tell me what's your problem.
Well, I have a Codman-Haycom shunt set at 90 millimeters H2O. Recently, I'm getting acute onset of headaches, and it's worsening day by day. I am unable to sleep. The pain is constant and is worse with coughing, straining, and sneezing, as well as standing up.
What's your age?
40, doctor.
Did you take any medicines then?
Yeah, I've tried taking Imitrex as well as Motrin 800 milligrams twice a day, but it has not provided much relief. Although the pain is generalized, it is quite intense in the frontal region of head. I get a feeling of ringing in the ears. I have been experiencing intermittent blurry vision and dimming lights as well.
Do you drink or smoke?
No, doctor.
Well, I've reviewed your diagnosis reports. Your physical exam reports show blood pressure at 153/86, pulse at 63, and respiratory rate 16. Cranial nerves intact for extraocular movements. The shut site is clean, dry, and intact. You have a small 3mm to 4mm round scab that was noted farther down from her shunt reservoir. It looks like there's a little bit of dry blood there. The worsening headaches are secondary to shunt adjustment back after an MRI. You have pseudotumor cerebri without papilledema and migraine headaches. Well, your shunt back programmed to 90mm H2O last time was after confirmation of an X-ray. However, it seems the picture of the X-ray last time was not most desirable. Therefore, I'm planning the shunt back to 90mm H2O again tomorrow. So, you have to have another skull X-ray to confirm the shunt back program to 90mm H2O.
Extract 2. Questions 13 to 24. You hear a physician talking to a patient called Thomas Andrews. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Good morning, Doctor.
Good morning. Have seated. May I know your problem?
Well, I'm a patient with hypertension, chronic intermittent bipedal edema, and recurrent leg venous ulcers. I had a vascular surgery for non-healing right ankle stasis ulcer. I have a serious concern today that I had a low-grade fever of 100.2 early this morning. Otherwise everything was well. The thing is, I was not even aware of the fever. I do have some ankle pain, worse on the right than the left.
Okay, what's your age?
52, Doctor.
Do you drink or smoke?
No, Doctor.
Are you getting nausea, vomiting or diarrhea?
No, Doctor.
May I know your previous illness history?
Well, hypertension, exploratory laparotomy in 2016 for abdominal obstruction, cholecystectomy in 2017, chronic intermittent bipedal edema, venous insufficiency, chronic recurrent stasis ulcers.
What medications are you taking?
Primaxine, daptomycin, clonidine, furosemide, potassium chloride, lisinopril, metoprolol, ranitidine, colace, amlodipine, zinc sulfate, Lortab, multivitamins with minerals.
Are you allergic to any medicine?
No, Doctor.
Well, the physical examination shows heart rate 73, respiratory rate 20, blood pressure 104/67, temperature 98.3, and oxygen saturation 92% on room air. There is hyperpigmentation involving distal calf on both legs. There is an open wound on the right medial malleolar area measuring 9 by 5 centimeters with minimal serous drainage. Periwound is hyperpigmentated with a hint of erythema extending proximally to the medial aspect, distal third of the right lower leg. There is warmth but minimal tenderness on palpation of this area. There is also a wound on the right lateral malleolar area measuring 4 by 3 centimeters. Another open wound on the left medial malleolar area measuring 7 by 4 centimeters. Wound edges are poorly defined. Laboratory results show white blood cell count is 5.8 with 64% neutrophils. H&H 11.3/33.8 and platelet count 176,000. BUN and creatine 9.2 over 0.52. Albumin 3.6, AST 25, ALT 9, ALK-Phos 87, and total bilirubin 0.6. Chest X-ray shows chronic bivascular subsegmental atelectasis, likely related to elevated hemidiaphragm, secondary to chronic ileus. No absolute findings. You have multiple previous wound cultures positive for Pseudomonas, Enterococcus, and Stenotrophomonas. Fevers, right leg, ankle cellulitis, chronic recurrent bilateral ankle venous ulcers, hypertension. I am ordering 2 sets of blood cultures, injection with daptomycin and primaxine 4. I am ordering an MRI of the right ankle to check for underlying osteomyelitis. Follow-up results of wound cultures. Additional treatment and medications are upon follow-up.
That is the end of Part A. Now look at Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at the question 25. You hear a discussion about common types of neuropathic pain. Now read the question.
Hello, doctor. What are the common types of neuropathic pain?
Well, while there are countless types of neuropathic pain, some of the prominent types include carpal tunnel syndrome. Is caused by nerve compression in the wrists and causes pain in the wrist, thumb and fingers. Central pain syndrome can occur after nervous system damage, such as a stroke. Degenerative disc disease, one may feel neuropathic back pain if it causes damage to the nerves entering or exiting the spine. Diabetic neuropathy causes stabbing pain in the hands and feet of some diabetic patients. Phantom limb pain can occur in some patients after a limb is amputated. Postherpetic neuralgia is brought on by an outbreak of shingles and persists after the condition has cleared. Pudendal neuralgia is a type of pelvic pain caused by compression of the pudendal nerve. Sciatica is caused by compression or irritation of the sciatic nerve and often results in shooting pain that radiates down the back of the leg. Trigeminal neuralgia is characterized by shooting neck and facial pain. Question 26. You hear a discussion bronchodilators used to treat chronic obstructive pulmonary disease. Now read the question.
Hello, doctor. what are the different types of bronchodilators used to treat chronic obstructive pulmonary disease?
Patients with chronic obstructive pulmonary disease are often prescribed a bronchodilator, a type of medication for relaxing the air passages to help breathe better. Typically, the medications are inhaled through the mouth using a metered dose inhaler, but also come in liquid, pill, injectable or suppository formulations. The three classes of bronchodilators commonly used to treat chronic obstructive pulmonary disease are beta-adrenergic, beta-agonists, anticholinergics, methylxanthines. Beta-adrenergic agonists are a type of medication that binds to specific receptors in the lung called beta-adrenoceptors. By doing so, they block the trigger to bronchial spasms and allow airway passages to open. Beta-agonists can either be short-acting or long-acting, which are delivered either orally or through a metered dose inhaler. Generally, the inhaled method is preferred as it alleviates symptoms faster. Anticholinergic blocks the neurotransmitter acetylcholine in the central and the peripheral nervous system to its receptor in nerve cells and inhibit parasympathetic nerve impulses. Methylxanthines affect not only the airways but stimulate heart rate, force of contraction, and cardiac arrhythmias at high concentrations. Question 27. You hear a discussion about pancreatic neuroendocrine tumors. Now read the question.
Doctor, what are the various types of pancreatic neuroendocrine tumors?
There are different kinds of functional pancreatic neuroendocrine tumors. Gastrinoma usually forms in the head of the pancreas and sometimes forms in the small intestine. Most gastrinomas are malignant. Insulinoma forms in the head, body or tail of the pancreas. Insulinomas are usually benign. Glucogenoma forms in the tail of the pancreas. Most glucogenomas are malignant. VIPomas, which make vasoactive intestinal peptide. Somatostatinomas, which make somatostatin. Question 28. You hear a discussion about melasma and different types of melasma. Now read the question.
Hello, Doctor. What is melasma and what are the types of melasma?
Well, melasma is a common patchy brown, tan or blue-grey facial skin discoloration, normally seen in women during their reproductive period. It typically appears on the upper lips, upper cheeks, forehead and chin of women of 20 to 50 years of age. There are 4 types of pigmentation patterns are diagnosed in melasma: epidermal, dermal, mixed, and an unnamed type found in dark-complexioned individuals. The epidermal type is characterized by the presence of excess melanin in the superficial layers of skin. Dermal melasma is defined by the presence of melanophages throughout the dermis. The mixed type includes both the dermal and epidermal type. In the 4th type, excess melanocytes are present in the skin of dark-skinned individuals. Question 29. You hear a discussion about possible causes of arthritis. Now read the question.
Hello, doctor. Can you tell me what are the possible causes of arthritis?
Osteoarthritis is associated with cartilage damage. Genetic conditions are thought to play a role in osteoarthritis. Age alone is no longer seen as the cause of osteoarthritis. Rheumatoid arthritis is an autoimmune disease that develops as the immune system malfunctions and attacks the body's own tissues. Gout develops when excessive uric acid accumulates in the body and crystals are deposited in the joints. Reactive arthritis causes joints to become inflamed as a result of an infection that triggers the immune system. Usually, this condition resolves. Question 30. You hear a monologue of a physician on granulomas. Now, read the question. Granulomas are tissue nodules of immune cells that occur in diseases such as sarcoidosis and tuberculosis that can damage many organs. It is the chronic activation of the metabolic sensor mammalian target of rapamycin that is responsible for the granuloma's formation. In sarcoidosis, this mechanism leads to a course that is chronic and difficult to treat. Since mammalian target of rapamycin inhibitors belong to a group of drugs already licensed for clinical use, these findings offer new and quickly testable treatment options.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
You hear part of a presentation by Jessica Stokes on a study related to dietetics. You now have 90 seconds to read questions 31 to 36.
Hello everyone and welcome to this year's Dietitians Summit. My name is Jessica Stokes and I am a researcher working with a team based in Cambridgeshire. It's great to have this opportunity to share our research so that we can better advise the patients and other healthcare professionals that we work with, especially as many of us move into roles in primary care and hospital settings and become integral members of teams. So, the research that I want to talk to you about today is about coconut oil and blood lipids. This is an important area as coconut oil, an oil high in saturated fat, approximately 90%, has gained popularity as a dietary ingredient throughout the UK. You may have noticed television cookery programmes, recipe books, as well as social media posts making claims of health benefits associated with the consumption of coconut oil. So, naturally, researchers have started to conduct intervention studies, and 2 recent reviews of such studies on the effect of coconut oil on cardiovascular risk markers provide no suggestion that consumption of coconut oil rather than unsaturated plant oils would benefit cardiovascular health. Rather, these reviews suggested that compared to unsaturated oils such as safflower, soybean, and olive oil, consumption of coconut oil raises total cholesterol, low-density lipoprotein cholesterol, as well as high-density lipoprotein cholesterol. However, both reviews highlighted the limited number of intervention studies to date, and that those available often had small number of subjects and were conducted in populations not largely representative of the UK, such as Sri Lankans and Malaysians. For this reason, a new randomised study was carried out. The aim of this study was to investigate the effect of daily consumption of 50 grams of either extra virgin coconut oil, extra virgin olive oil or butter for 1 month on blood lipids and other metabolic measures in free-living UK subjects. The findings from this randomised study were recently published. So, before getting into what you are all so eager to hear, the results, I will talk a bit about the study design. So, in this trial, middle-aged men and women living in the general community were randomly allocated to consume 50 grams of extra virgin coconut oil or 50 grams of butter or 50 grams of extra virgin olive oil over 4 weeks. Subjects who did not have a known medical history of heart disease, stroke, cancer or diabetes, and without gallbladder or bowel problems, not taking cholesterol-lowering medication, and living near a particular town were recruited through advertising over 2 months in 2017. In all, 96 subjects were included in the study. 2/3 of the subjects were women, and the mean age was 60 years of age. Another important factor, the mean BMI for the 3 groups, ranged from 24.8 to 25.5. Dietary intake, as assessed by a 24-hour dietary assessment questionnaire done before the study began, was similar across the intervention groups. Plasma lipids were found to be raised at baseline in all groups. Study fats were provided along with measuring cups and suggestions of how to include the fats in the diet, including recipes. Just to make sure we're all on the same page as to the study fats, extra virgin coconut oil has a saturated fat content of 94%, followed by butter with 66%, and finally extra virgin olive oil with 19%. So now to the big reveal. The first finding was that coconut oil did not significantly raise LDL-C concentrations compared with olive oil, while butter significantly raised LDL-C concentrations compared with both coconut oil and olive oil. On the other hand, coconut oil significantly raised HDL-C concentrations compared with both butter and olive oil. As to body weight, BMI, central adiposity, fasting blood glucose, systolic or diastolic blood pressure, there were no significant changes in any of the groups over the period of the study. The conclusion that the author drew from the results is that 2 different dietary fats, butter and coconut oil, which are predominantly saturated fats, appear to have different effects on blood lipids compared with olive oil, a predominantly monounsaturated fat, with coconut oil more comparable to olive oil with respect to its effect on LDL-C. As with any study, there are a number of limitations to point out. First of all, the study was short-term in nature. In addition, the study did not include a run-in period. According to the EFSA, blood lipids tend to stabilise after about 4 weeks in response to fixed nutritional interventions, so future studies should be longer in duration to collect evidence on the sustainability of the effect with continuous consumption of the food, or in this case, fat. Another factor is that there was no attempt to control other aspects of the usual diet, in particular total energy intake. Related to this is
Now look at Extract 2. Questions 37 to 42.
You hear a training by Dr. James Coffey about a non-surgical procedure. You now have 90 seconds to read questions 37 to 42.
So, today we're going to go over sputum sample collection, which is a procedure designed to collect expectorated secretions from a patient's lower respiratory tract. This procedure is normally used as a laboratory specimen for the isolation of microorganisms that might be causing infections of the respiratory tract. So, before getting into the procedure itself, it is important to know what patients are indicated for sputum collection. In general, this procedure is recommended for all patients with moderate and high risk, according to the CURB85 pneumonia severity score, as well as those with suspected tuberculosis. Just as a reminder, the CURB85 pneumonia severity score includes the following criteria: confusion, a respiratory rate less than 30 per minute, blood pressure with diastolic higher than 60 or systolic higher than 90, the age of patient being equal to or higher than 65 years, and the level of blood urea nitrogen being lower than 19 milligrams per deciliter. A score of 2 or above indicates higher risk. On the other hand, sputum collection should not be performed in patients to whom severe coughing may be harmful. This may include patients with acute respiratory distress, unstable cardiovascular status, hypoxia, and lung function impairment, among others. Another step to complete before carrying out the procedure is to gather all of the equipment. In order to obtain a sputum sample, you will need to gather the following equipment. To protect yourself, you will need appropriate personal protective equipment, such as clean gloves and an apron, and a mask, gown, and goggles if the patient is likely to have tuberculosis or another high-risk infection, such as influenza or Legionella. In order to carry out the procedure, you will need a sputum specimen container and label, a biohazard for delivery of the specimen to the laboratory, as well as an investigation request form. Last but not least, you will need tissue paper for the patient, as the procedure produces severe coughing, as I mentioned previously. So, once it has been determined that a patient is to undergo this procedure and you have all of the required equipment, you can go about collecting the sputum sample. As with any similar procedure, you must explain the procedure to the patient. You might say something like, "Hello, Mrs. Jones. My name is Dr. Smith. We need to collect a sample from your lungs to be able to identify which bug is causing the infection in your chest. The procedure includes breathing in and out, coughing, and collecting sputum in this pot. It might cause you to cough heavily straight after, but it shouldn't be too uncomfortable. Then you should check the patient's understanding of the procedure and obtain consent before washing your hands again." So, the last step before collecting the sputum is to have the patient rinse their mouth before coughing. This is to remove any oral contaminants present in the patient's saliva. After that, you need to instruct the patient to give a series of low, deep coughs to raise sputum from the lungs. The patient will need to keep breathing out until his or her lungs are completely empty. The test will be more accurate if the patient coughs up sputum from deep inside his or her lungs. For many patients, it is helpful for them to put one hand over their mouth with the tissue you will provide them and then put the other hand on their stomach. This will help them feel if they are coughing deeply, as they should be able to feel it in their stomach. You may also find it helpful to pat the patient on the back. This should be done solidly up and down the back to help release the sputum. You then need to collect 1 or 2 teaspoons of sputum in the container before closing and sealing the lid. If your patient has a tracheostomy or is intubated and ventilated, you will need to vary the procedure, as you will likely need to use a suctioning device such as a suction trap. Also, for patients that find it very difficult to expectorate, a 9% sodium chloride nebulizer might help to loosen secretions. Finally, you need to correctly label the specimen container and complete the request form before placing the specimen in a biohazard transport bag. You should
I wonder how head injury can lead to a condition like this.
I realize your anxiety. Definitely, I will help you to sort it out. But before moving further, would it be okay if I can ask you some questions?